Hello, I'm Dr. Vallerie McLaughlin. I'm the Kim A. Eagle Endowed Professor of Cardiovascular Medicine at the University of Michigan, and I'm also the Director of the Pulmonary Hypertension Program here. Now, at University of Michigan, we have a very large pulmonary hypertension program, and I feel very privileged to work with a number of colleagues that make this multidisciplinary program function very well. There are 3 physicians who work in our practice, 2 nurse practitioners, and 3 nurse clinical care coordinators. We also have clerical support, support from PharmDs, prior authorization support, MAs, medical records, dietary, social work, and other disciplines within the university. We work well with our pulmonologist, our gastroenterologist, sometimes infectious disease, cardiac surgery, lung transplantation. So we have a really large multidisciplinary program, and I'm really thrilled to be able to share some aspects of our clinical practice with you today, specifically with respect to treating Group 1 pulmonary arterial hypertension. We're going to talk a little bit about treatment selection and how risk assessment is so important as we go through the treatment algorithms. We'll talk a bit about combination therapy, oral combination therapy, the smaller proportion of patients who need upfront combination therapy with triple therapy, including parenteral prostacyclins. We'll talk a little bit how we manage combination therapy in our practice. And then, of course, we'll look a little bit into the future. You know, pulmonary hypertension is an area that's evolved so much out over the past couple of decades. When I first started doing this 2 decades ago, we really just had one therapy, and now we have more than a dozen and lots of clinical trials, lots of new potential mechanisms of action on the way. So we're really, really excited about what's going on in pulmonary hypertension. So let's talk about some important questions. One is really how our practice has evolved over the recent years and what impact some of the recent clinical trials have had on the clinical recommendations for the use of combination therapy. Well, there are 2 or 3 different algorithms for pulmonary arterial hypertension treatment. Certainly, there's the ESC-ERS guidelines, which were last published in 2015. There's another set of those under development, which should be available in 2022. There is the algorithm from the 6 World Symposium that was published in 2019, and there's the American College of Chest Physician guidelines. And they all have little tweaks to them, but there are some very important concepts that come out of all of them. And there were a few clinical trials over the recent years that I think really impacted those guidelines. Probably one of the most important game-changing clinical trials was the AMBITION trial, and that was published in 2015. And the main question in the AMBITION trial was, is upfront combination therapy with 2 agents, ERA, PDE5, in this case, ambrisentan and tadalafil, is that better than either an ERA, ambrisentan, or a PDE5, tadalafil alone? It was a practice-changing clinical trial which demonstrated the benefits of upfront combination therapy with an ERA and PDE5 in patients with Group 1 pulmonary arterial hypertension. There was a substantial improvement in exercise tolerance as measured by the 6-minute hall walk with double combination therapy. And there was less clinical failure in patients that got double combination therapy. So that trial really revolutionized our therapy. And most of the guidelines now suggest that unless you're at very, very high risk and you need upfront parenteral therapy, or unless you're at extraordinarily low risk, in which case monotherapy may be okay, the majority of the patients get started on upfront combination therapy with an ERA and PDE5. And certainly we have evolved into that as a standard in our practice. I would say here at the University of Michigan, probably maybe 10% of the Group 1 PAH patients that we see at initial diagnosis have so many high-risk features that they need to go on upfront combination therapy that includes a parenteral prostanoid. So about 10% go on upfront. IV therapy, usually with oral therapy as well. So I would say in our practice here at Michigan Medicine, the majority of our patients start on upfront combination oral therapy with an ERA and PDE5. Perhaps 10% are so sick that they start on combination therapy that includes a parenteral prostanoid. And a small percentage of our patients fall into that very low risk category where we just use one oral therapy. Those are primarily the patients that are diagnosed very early when they are screened aggressively in the scleroderma clinic. But the majority of patients start on double upfront combination therapy. Now, since Ambition, there have been other trials looking at combination therapy. We have a fair amount of data on combination therapy from the Seraphin trial, which was a large endpoint-driven trial of macitentan, and a large proportion of those patients were also on a PDE5 inhibitor. We also have a lot of combination therapy from data from the Griffon trial, which was a trial of selexipag. And in fact, we have some good triple combination therapy data from that trial. About a third of the patients in that trial were on an ERA and a PDE5. And so those patients who were randomized to triple or to selexipag were on triple therapy. And that subgroup had just as much of a benefit in the primary endpoint, about a 40% risk reduction in events in comparison to patients who didn't come in on any therapy or only came in on one therapy. And then, of course, Triton was recently presented. It's not yet published, but it was recently presented at meetings. And the primary endpoint of Triton was hemodynamics, and that was no different between the newly diagnosed patients who started on double upfront combination therapy with macitentan, tadalafil, and placebo versus triple upfront therapy with macitentan, tadalafil, and selexipag. So nearly a 50% reduction in PVR in both groups, about a 50-meter improvement in hall walk in both groups. So both groups improved substantially, but there was not a difference between those two groups. An exploratory analysis suggested that maybe there was a difference in events, and that needs to be interpreted cautiously as the primary endpoint was not met, but certainly a signal that is consistent with what we saw in Griffon. So in our practice, I would say we generally follow the 6 World Symposium algorithm. I'd like to highlight that this applies to patients with group 1 pulmonary arterial hypertension, not other types of pulmonary hypertension. So group 1 disease, a small proportion of those patients will have an acute response to vasodilators and might be appropriate for calcium channel blockers. The majority of patients do not. Of those patients who do not, there are a few high-risk patients who need initial combination therapy, which includes a parenteral prostacyclin, perhaps a residual role for initial monotherapy in a small proportion of patients. But the majority of those patients get initial double combination therapy. So let's move on to another question. Let's talk about what we think about what considerations there are when we decide on the use of oral combination therapy. Well, I think there's great data with oral combination therapy for ambrisentan and tadalafil, which is what was studied in the Ambition trial. I also think there's really good data on macitentan and tadalafil from the Optima study, and we also got that data from Triton, a 50% reduction in PVR, 50-meter improvement in hall walk. So a little bit of data on macitentan and sildenafil from Seraphin. So I do think that there are different options for the combination of ERA and PDE5. How I approach this in my clinical practice is when I think a patient is in that intermediate risk group, don't need IV, too sick for monotherapy, and I want to prescribe upfront combination therapy. First of all, I educate them about the disease state. I educate them about all 3 pathways. I want them to know about the prostacyclin pathway too, so that they're open to that should they not improve adequately and that they need a prostacyclin pathway agent at some point. So I want them to understand that therapy. But then we talk a lot about the ERAs, the PDE5s, what the goals of those therapies are, what the side effects are. I think it's important for the patient to understand what we're trying to achieve. And I explain this to a patient as both a short-term goal, and they really understand the short-term goals, right? They come to us short of breath. They can't go up the stairs. They can't take care of their house. So they understand their short-term goal is feeling better, is being able to do more, being able to function better in their everyday life. So that's pretty easy. But then I also explain to them the long-term goals, that over the long term, we want their disease to improve. We want them to be at less risk of disease progression, of needing parenteral prostacyclins, and in fact, dying. And I try to explain to them that we want to achieve certain targets in terms of their risk assessment. And some of that is measured by the Hall Walker blood tests or the heart cath, but we want to get them into that low risk status so that we can improve their long-term outcomes. So I ask the patient to think about it both in terms of the short-term effects, which they feel, and the long-term goals of really controlling their disease and improving their prognosis. I think it's really important to talk about the side effects of these medications and to talk about the tips and tools that we have to help manage their side effects, and to let them understand that we have a whole team behind them. We have our nurses, our nurse practitioners. We often do a video visit with them a month after they start a new therapy just to help manage their side effects and help reassure them, see if there's anything else we need to do to help improve their retention on therapy. And I generally only start one therapy at a time. I know we talk about upfront combination therapy, but that doesn't necessarily mean it's the same day. In fact, I like to separate it by about a week so that if a patient is having side effects, we know what medication caused that. So if I'm going to prescribe an ERA and a PDE5 to a patient, I'll submit all that paperwork. There's a prior authorization process. They generally will get one before the other. I tell them to take whichever one they get first, start that one first, and then to start the other one about a week later. So I think that really helps manage the patient's side effects and expectations. So I want to tell you a little bit about my clinical experience with combination therapy and what some of the patients have told me, what some of the outcomes that I've seen have been. I think in general, our experience with combination therapy is pretty good. It doesn't work for everyone, but I think it's a good option for many people. I think times have changed. You know, a decade or two ago, when a patient got diagnosed with pulmonary arterial hypertension, there was only one therapy. It was a lot easier. There just wasn't a decision to make. And now it is a much more complicated discussion with the patient. We need to make sure they understand all the therapeutic options. We need to make sure they understand their risk. And it becomes really more of a shared decision-making process. There's certainly some patients who have advanced hemodynamics that I would love to see on a parenteral prostacyclin therapy who really say, gosh, I've heard about these oral therapies. Can we try that? And most of the time, not all of the time, but most of the time, the answer to that is yes, as long as you watch them really, really carefully. So I think it's important to have that conversation with the patient, make sure they understand the potential benefits, the risks, make sure that they have the adequate follow-up, that they know the side effects, that we share with them the tools to manage the side effects, because that's really going to help improve retention on therapy. I would say a large majority of the patients get better on upfront combination therapy. I think the key is that reassessment at 3 months, 4 months to see what their risk status is. The goal is to get the patient into a low risk status. And if they have not achieved that, if they still have functional class 3 symptoms or suboptimal hall walk or an elevated BNP, they need something more. We may need to repeat a right heart cath to see what we're dealing with to determine if that's something more, can be an oral therapy or a parenteral therapy. But I really need to highlight that the most important part of the algorithm, I think even more important than what that first therapy is how they respond to the first therapy, what their risk status is after that 3 to 6 month time frame. Because if they're not at low risk status, that's the time you want to do something more. That's the time you want to escalate therapy and try to get them into that low risk status. So I would say even with how highly effective oral combination therapy is with an ERA PDE5, not everyone is going to get into that low risk status with those two therapies. In fact, some of the recent literature suggests that less than half of our patients will get into that low risk status. So we need to be very thoughtful about that 3-4 month reassessment and escalate therapy if they have not reached the low risk status. So let's talk about what the future of combination therapy is. We certainly have a wealth of data now on combination therapy from clinical trials, and it's very telling. But I think the problem that we have right now is it's not necessarily being translated into clinical practice. I think despite all of the data that we have on combination therapy from clinical trials such as Ambition and Seraphin and Griffon, we find that our patients in clinical practice in registries aren't meeting goals, aren't getting to low risk, and aren't being escalated to combination therapy as rapidly as we'd like. So one of the things I'd like to see happen in the coming years in pulmonary hypertension is a real emphasis on that risk assessment 3 to 6 months after diagnosis and really escalating therapy if a patient is not hitting the low risk status. And we have lots of ways to do that now. The prostacyclin pathway is very important at that point. Some patients will need parenteral therapy, but there are many other options. There are oral and inhaled options as well for those patients who aren't quite at low risk status, but aren't so high risk that they need parenteral prostacyclin therapy. I think we're also in a very clinical trial rich period right now. There's a number of therapies with new mechanisms of action that may provide incremental benefit on top of the 3 pathways that we currently have. There was recent data of a phase 2 trial with sotatercept, which targets the BMPR2 pathway, released recently, a dramatic improvement in hemodynamics and hall walk. This may be another option. There's a number of kinase inhibitors being evaluated right now. Just a lot of other therapies that could potentially attack different mechanisms of action than the 3 pathways that we have addressed over the years. So I'd like to sum up. We talked a little bit about therapy for group 1 pulmonary arterial hypertension today. We highlighted some very important data on combination therapy, and almost all of our patients start on combination therapy right now. The sickest of the sick start on aggressive combination therapy that includes a parenteral prostacyclin agent. However, the large majority start on double oral combination therapy. I think the key message that I want to get out is the importance of that reassessment at 3 to 6 months to determine if the patient's in that low risk status, and if not, really emphasizing that something more needs to be done, and often that's adding a prostacyclin pathway agent. And of course, we've come a long way in the past 20 years. We have many therapies for pulmonary arterial hypertension that target 3 pathogenic pathways right now, and there's a number of clinical trials looking at novel mechanisms of action. So I hope that in the future we have some new therapeutic options for our patients. So I've really enjoyed spending this time with you today. I'd like to remind you to complete the post-test and the evaluation to receive CME credit. Thank you.